cutting on lots of topics to manage my time well. Heel pain, it is one of the most common presentation in an orthopedic OPD. Heel pain can occur at any of the area like posterior, plantar, medial or lateral. It could be from a local source or a remote, like as in from spine. It could be arising from soft tissues as well as from bones. We'll focus on plantar and posterior heel pain. Now, the most important differential diagnosis for plantar heel pain is proximal plantar fasciitis, mid-plantar fasciosis, plantar fascia rupture, plantar muscular strain or rupture, calcaneal stress fracture, plantar fibromatosis, infracalcaneal bursitis, fat pad atrophy, and Baxter nerve entrapment. Unfortunately, all these differential diagnoses lie very close to each other and require a meticulous history and examination to come about very near to what are we actually dealing with. Coming to posterior heel pain, Achilles tendon pathology, we all know about it. We know about flexor hallucis longus tendinitis, enthesopathy or inflammatory arthropathy, pre-Achilles bursitis, posterior ankle impingement, and Hagelin deformity. Now let's talk about Achilles tendon pathology and let's see some terminologies. What is insertional tendinitis? Inflammation at the insertion of Achilles tendon into the calcaneal tuberosity. Non-insertional tendinitis occur proximal to the insertion of Achilles tendon. Paratendinitis, it is the inflammation of paratendon and septum. Tendon is spared. Tendinosis is asymptomatic degeneration of tendon without any inflammation. And tendinitis is actually dysfunction. There is decreased vascularity, which is reflected by the inflammatory response. What are the reasons for Achilles tendon pathology? Most commonly, impact sports like running and jumping, uneven training on uneven grounds or training errors, postural problems like hyperpronation or flat feet, varus feet, ankle instability, and cavus feet. And definitely, Hagelin deformity is one of them. Systemic diseases play a role like diabetes, obesity, gout, inflammatory arthropathies, hypertension, systemic steroids, hyperlipidemia, sarcoidosis, and also the drugs like oral contraceptive pills, fluoroquinolones, and drugs used in renal transplant have been documented to cause Achilles tendon pathology. Classifying the Achilles tendon pathology based on the duration of symptom. Acute if they are less than 2 weeks old, subacute if they are 3 to 6 weeks old, chronic if they are more than 6 weeks old. Then Klein and Baxter came up with non-insertional and insertional Achilles tendinopathy. We have already seen what are they. Then Putu came with classification based on the stage of inflammation. The first stage is paratendinitis, where there is only inflammation of paratendon, tendon is normal. The second stage is a mixture of paratendinitis and tendinosis, where inflammation process involving the paratendon along with degeneration of tendon occurs. Clinically, fullness is there with shifting of tenderness with ankle range of motion. There is a high risk for tendon rupture. There is poor vascularity, mucoid degeneration, and striking absence of reparative process. Tendinosis is the last stage where there is asymptomatic tendon degeneration without concomitant inflammation. Clinically, there is marked absence of inflammation, but tenderness shifts on ankle range of motion. Interstitial rupture, partial rupture, and acute rupture can develop. And also, even the tendon distant from the site of rupture can be abnormal. How do these patients present? Initially, they complain of pain in the initial morning when they do activities and exercise. Then the pain starts in normal walking and running. Then pain ultimately comes with even rest. On examination, on inspection, there is a para-Achilles fullness, edema and erythema. On palpation, there is localized tenderness and swelling, decreased range of motion. Tendon could be thickened or there is increased temperature, nodularity, or even a defect can be felt. Thomson test, it was very well elucidated by Dr. Kamal Dureja sir in the first lecture. Now, what investigations can we do? X-rays, very common. Cortical erasions with osteopenia can be seen. Tendon calcification can be seen. A Hagelin deformity again, and osteotrigona. MRI, a T2 weighted image, high intensity signal reflects intrasubstance pathology like edema, hemorrhage, scar within or around the tendon. Ultrasound gives rapid real-time evaluation. It is operator dependent and it's less specific for insertional disorders. Now treatment. Conservative care is the mainstay, and believe me, most of the patient get away and get good with conservative care. Physiotherapy, non-steroidal anti-inflammatory drugs, rest, immobilization, and orthotics are the main points here. In non-operative treatment, eccentric strengthening, cryotherapy, pulse ultrasonic therapy, dexamethasone labeled ionotophoresis, orthotics, and brisement are the mainstay. Also, shockwave therapy are used at various centers. When it comes to surgery, there are certain contraindications. The relative contraindication is diabetes, smokers, and poor skin condition. And the indications are disease which are more than 6 months. There is a failure of conservative treatment for more than 6 months, and when the Achilles tendon rupture. The criteria for debridement and reconstruction for non-insertional degeneration. If it is less than 50% of diameter, do a debridement, intrasubstance repair, and early mobilization. More than 50% of diameter or more than 6 centimeter of length involvement, resection of degenerated tendon, proximal VY advancement, and or FHL tendon transfer. If defect is less than 6 centimeter, proximal VY advancement or central third turn down is also an option. Post-op care, below knee cast with 10 degrees of equinus at 2 weeks, make it 5 degrees of equinus at 4 to 6 weeks, a walking boot with a heel lift, weight bearing tolerated with progression to full weight bearing over a 4-week time period. Range of motion and strengthening exercises are initiated at 4 to 6 weeks. At 6 to 8 weeks, full weight bearing is allowed. At 3 months with the walking boot, 3 months, progressive strengthening program has to be started. Athletic activities are started only after 6 months. Now, surgery for insertional tendinopathy, there is excision of bony prominence and retrocalcaneal bursa, removal of degenerated tendon and calcification. We refix the tendon after doing all these procedures. The fixation method could be suture anchors, speed bridge technique, or simple position via bone tunneling. These procedures can be done open midline or via endoscopic. In open technique, we have...
Excuse me, Abhishek, these has been discussed with Parthiban. You are crossing now. We are left with I wanted to differential diagnosis of the plantar and then the treatment. So can you just move on to plantar heel pain? Otherwise, that will be left. You have
we are almost there, sir. So now we come to plantar heel pain. Let's talk something about plantar fascia. It's a broad multi-layered fibrous aponeurosis extending from anteromedial aspect of calcaneum and inserting into periosteum of base of proximal phalanx. Only the central and medial band constitute plantar fascia. It's relatively inelastic. Why does plantar fascia... Hello?
Only 2 minutes left.
Yeah. So the main reason why plantar fasciitis occurs, it can be blamed on Will-Last mechanism. There is a toe dorsiflexion upon which a high tensile force is concentrated, especially in runners and standing workers. Repetitive activation of Will-Last tensile overload, micro tears, inflammation and degeneration at plantar fascia origin. The causes are multifarious, increasing age, obesity, degenerative changes, and arch abnormalities. Now, one thing has to be we are very sure about it. A plantar calcaneal spur has got nothing to do with plantar fasciitis. Now, clinical picture, they suffer from post-static dyskinesia, that is pain occurs with the first step in the morning, gets better with activity unless they overextend themselves. Pain occurs at the push-off and not at the heel strike. This is very important. The location of pain is medial tubercle, though gait modification can cause symptoms laterally as well. NSAIDs generally do not work. The differential diagnosis for plantar heel pain is tarsal tunnel syndrome, plantar fibromatosis, flexor hallucis longus tendinitis,
1 minute left.
Central heel pain syndrome, plantar fascia rupture, stress fracture of calcaneum, tumor infection, inflammatory arthropathy, and pain coming from spinal origin. I'll skip these. Management, physiotherapy involving calf, hamstring, and plantar fascia stretch, cryotherapy, and appropriate footwear. Night splints can also be given, but beware of tibial and sural nerve neuritis, traction neuritis. Injection will be given, custom orthosis, and pulse wave therapy. Injection, we do give dipomedrol. As far as therapy is concerned, it's controversial. Shockwave therapy can be given. And eventually, medial gastrofascia release and also Stender's release, which can be open or endoscopic. Thank you.
Thank you so much. Any burning questions anybody has before I go on to cases? Can I ask Parthiban one thing? Parthiban?
Yeah, sir. Yeah, Pradeep.
The flow chart which you had shown for the defects, is that your flow chart or is there a reference for it? Because it's slightly different numbers which you would normally would talk. I think the rest of the faculty would agree on that.
Yeah, it was on my own. It was not from any particular this thing. Yeah.
No, that's
Which
fine.
was the differences you felt?
Okay. So anything else? Any other faculty want to add onto it before I go on to the cases? We have exactly, I'll take only 20 minutes or even less. We have 4-5 cases from all the speakers joined in. May I start?
I think you should start.